if you're going to offload something and create a well or depression, every time the person takes a step, that prominence is going down into that depression that you created. So there's shear and friction. Every time they take a step, there's shear and friction when it goes down into that area that you created an offload or relief in. So really pay attention to shear and friction. It's a major, major contributor to foot problems, especially on the plantar aspect with our diabetes population. Dry cracking skin, with our because we're talking diabetes here. The autonomic system, when we think of peripheral neuropathy, we think of sensory. That's what everybody right away thinks of with peripheral neuropathy, is sensory loss. But it also affects the motor system and the autonomic system. And the autonomic system is responsible for the hydration of the foot. A nice supple foot has oils and everything else, but if you have some of the patients that we have, it's dry skin, and if they're not doing something to moisturize it, that skin eventually just breaks down, it cracks, and that's a portal of entry for an infection. So the dry cracking skin is a common cause. And then on the other side is maceration. I say they should put some lotion on their feet to keep them supple. Then, of course, if a little is good, a lot's better. And some people will use so much that they end up with all kinds of lotion or cream in between their toes, and they end up macerating. Or maybe because of the autonomic system, they're hyperhydrated. They're sweating too much, and they get maceration between the toes. So, our diabetes population has so many things going on with them, and we need to understand all of those things so that we can guide them and protect them. Burns, again, because they don't recognize, they don't feel temperature. And then foreign objects in the shoes, and I'm sure we all have horror stories of different things that we found in the shoes. I mean, I had one guy that came in, they were putting a roof on his house, and I had trouble getting his boot off, and I got it off, and his foot was bleeding, and he had a roofing nail up through the bottom of the boot. So, and he had no clue that it was there. So, foreign objects involved again with that loss of sensation is a big deal. Common areas, as I think I said, it more distally in the foot, because that's the farthest from the heart and the brain and all that other stuff. So when we use the monofilaments, if you're using a monofilament to check for sensation, they've actually gone, some of the companies have actually gone to just advising to test out in the metatarsal heads and the toes, because that's where it's going to start. You think about it, many of the amputations, even the below knee amputations, started with a toe or a metatarsal amputation. So we look at so many of the amputations distally. Distal end of the great toe, that's probably because they had some hallux rigidus or hallux limitus, and they were just pivoting and pushing off on that great toe all the time. Or the shoe was too short. And that too, a lot of your folks, you think of it when you're fitting them with shoes, they would like the shoe as small as possible. And always remember, they've lost sensation, but when we say lose sensation, that can be a multitude of different things. That's not just that they feel that monofilament. Some of them won't feel that nail in their foot. Some of them, they can't do any of that, but they can feel pressure. And they want to feel the shoe on their foot. So they'll ask you, or they'll fit themselves very, very small so that they can feel the shoe. The shoe feels secure on their feet. So the sensory loss can be so many different things. So the distal end would be the shoe too short. Plantar aspect of the great toe, as I said, would be hallux rigidus. The metatarsal heads, again, a lot of our diabetes patients that we're seeing they're not kids. Vast majority of them are probably elderly people. If you're doing a therapeutic shoe bill, they're 65, 75, 85, and 95. So they've got arthritis, all different things, aging. We're not just treating diabetes when we're looking at those kind of feet. So you get very, very prominent metatarsal heads, and if those aren't relieved, they're going to break down. Base of the fifth metatarsal head, I see a lot of cavus feet, in the diabetes population. And again, that can be contributed to that autonomic, the motor function that's modified or affected by the peripheral neuropathy. Again, the motor function is affected, and you'll see real severe cavus feet, and then you've got that real prominent base of the fifth metatarsal. And with the shoes that we're putting on people now, always remember they're sitting down in the sole of the shoe. So if you've got a prominent base of the fifth metatarsal, what's happening? It's rolling off the edge of the sole. And that's a perfect way to create a diabetic, an ulcer on that base of the fifth, because it's riding over the edge of the sole. It's like a knife just sticking up into that bony prominence. On the plantar aspect of the heel, again, loss of fatty tissue, as we see with our elderly population. The tops of the hammer toes, if they've got real severe hammer toes and they're not wearing shoes that are appropriate. And when I always talk about when I'm looking at hammer toes, always remember that those hammer toes, there's all kinds of hammer toes. A hammer toe, a mallet toe, a claw toe, they're not all the same. With those toe deformities, they can be flexible. You put a metatarsal pad in the right place, you might be able to relax those toes some. Some of those hammer toes are rigid, and they're not going anywhere. And then when you're fitting them in a shoe, you've got to be sure that you've accommodated that, because it's going to be rubbing all the time. It's not going to relax at all. And particularly in my diabetes population, I see some of those toes that are dynamic. Every time somebody takes a step, that hammer toe jumps up, and sometimes it jumps up a half or 3/4 of an inch. So when you're doing your evaluation, it's a good idea to have them take a couple steps and see what the toes are doing, because they're not always just sitting there and being obedient and staying in place. So, and then you're going to get at the dorsum of the top of the hammer toe, and then, but also, if we've got the hammer toes, where's the base of that of that metatarsal joint going? If you've got a hammer toe, it's driving the metatarsal head into the floor of the shoe. So you've got potential ulceration site on the plantar aspect as well as the dorsal. And then between the toes, like I said, I've had quite a few patients that I've done my foot exam and find ulcerations in between their toes. And that is quite common. And again, I'm not being critical, but a lot of these folks aren't getting down there and really doing a good job of washing their feet, just because of range of motion, a lot of different things. So be sure that when you're examining, you look in between the toes, especially with that insensate foot. So common treatments, just these are some of the things we'll throw out there. Obviously, total contact casting, in my mind, and I know that's not necessarily everybody, even the physicians don't all agree with that, but some still do, is a total contact cast. We just talked about finding a way to take a crow walk or a removable boot and customize it. Obviously, the ultimate would be a total contact cast. You put that cast on, it totally fits the foot and follows the entire plantar aspect of that foot, and it redistributes weight, and ulcers can close very quickly in that total contact cast. I've been doing this for 50 years. I spent time with Dr. Paul Brand at Carvel, Louisiana, and that's where the total contact cast came from. He developed that, he introduced it to us, and it works great. It's very time-consuming, it's costly, don't get paid a lot for it, so going to the removable boots is a great option. But it has to be the right boot, as we discussed already, with a good custom footbed. Debridement, the reason I put that there, and not that I don't think any of you, or I don't know, again, if we could have some physicians on listening to us here, but debridement is so necessary to close those ulcerations. I've had situations where doctors have sent people to me with ulcers and just said, provide with shoes and inserts. And that's okay if they're going back to the physician and the callus is being debrided. If that callus isn't being debrided, it's really a disservice, because the callus will close, and I've seen that with a lot of my patients that weren't going back on a regular basis to their physicians, the callus would close, and once it closes, then the infection can go wild inside of there, and they've ended up with osteomyelitis, where if that callus would have been debrided, when we're offloading, if you're involved in any kind of wound healing, the callus isn't closure. The callus has to be removed so that there's good viable skin, and that skin can actually heal and heal over the ulcer. The callus isn't going to do that. So if you're involved in working with a patient that you're trying to help heal an ulcer, you need a physician that understands the importance of debridement as well. You know, used to think that a dry environment was good for healing, but really now the concept is, and it's proven, a moist healing environment is preferable for the most part. Again, I'm not a physician. Foot of elevation, possible bed rest, though when Dr. Brand was introducing and looking at his total contact casting, that was his concept. And I was privileged to be down there when he was still alive and still, you know, managing the facility. And he thought that the total contact casting worked, and so and of course a lot of solutions was bed rest to get the person off of the foot. So he actually he did a test because he had inpatients there. So he was able to do research with the people that were living at Carvel. And he took two groups and did one group with plantar ulcers with total contact casting, one with bed rest. And he was watching the progress week to week. And all of a sudden, the bed rest people weren't doing well at all, and total contact casting was doing well, but it was so out of whack, he didn't understand. Obviously, he wanted the total contact casting to be a good method, but it didn't make sense. So he walked through the infirmary because he lived right at Carvel, so he was able to go into the infirmary in the middle of the night and walk around, and he'd get to some of the rooms that he knew were supposed to be total bed rest, and the light in the bathroom was on. And he did this for a while, and then he sat down with the nursing staff, and he said, okay, he said, you know, I'm working on this study, and I've got this group that's total bed rest, this group that's wearing the total contact cast. And he said, are we sticking to that? And of course, everybody said, of course. Doctor, you worshipped him. He was a wonderful, wonderful man, knowledgeable man. And they said, of course, Dr. Brand. And he brought it up to him. He said, well, I was in this room, and these people were in the bathroom in the middle of the night. And the nurses said, well, it was just to get up to go to the bathroom. And that made a difference. That made that much of a difference. So if you were going to do bed rest, it has to be bed rest with a bedpan and everything else, because getting up and walking, and that's why a lot of our patients, if they've had, you know, plantar ulcerations, we need to find some sort of a solution for them to wear at night when they get up to go to the bathroom, even when they're taking a shower and all those things. All those different activities can slow down healing or could open up another ulceration, a post-ulceration. Very, very important. When healed, when it's finally healed, that's really when we come into play with our total contact foot orthosis, shoes, rocker soles, and even possible AFOs, depending on how serious and where the post-ulceration is. Okay, so let's take a closer look. I'm going to go quickly through this. I don't know if any of you folks are using and dispensing wound care products. We did for quite a while here, actually because the hospitals and wound care clinics were having problems getting paid. So they asked if we would start providing this stuff, and we did, and guess what? We had a problem getting paid. So it really wasn't a real profitable thing for us at the time. So we're not really doing much of this anymore. We will work with the wound care and modify or make orthoses or inserts to go inside of the devices, but we're not dispensing too much of this anymore. We talked a little bit, I forget what his name was, I did talk a little bit about this. So here you've got the DH pressure relief walker. You know, you've got that insole that you can pull plugs out of there, and that will work well, but I don't know about you folks, but I've had some issues with that. If you don't put a cover, I usually, if I'm dispensing or working with one of these, I will pull the plugs under the ulceration or the prominence that we're trying to relieve, but I put a thin piece of plastizote over the top of it. And then you get a depression. If you don't do that, this particular material will sort of collapse and it collapses in varying degrees, and you end up with pressure again. If you put a piece of thin piece of plastic over the top, you actually get a nice depression, and I think it works better. Here you've got a pre-inflated bladder, you've got a rocker sole built into it, and Velcro straps for adjustability. So, you know, and again, when you're looking at one of these walkers, you want to try and get something that's very wide in the midfoot, because a lot of the Charcot deformity that we see is in that midfoot. It's a medial collapse. Pneumatic walker, here you've got the bladders that are adjustable. The concept obviously is to try and unweight the foot like the total contact cast does. You've got a dual density insole, rocker sole, and again clamshell design with Velcro straps. Okay, the healing shoes, a multitude of other of things that are out there. This is again a DH pressure relief shoe, and it's got that same insole in it that you can take the little pieces out to create relief. Again, I'm going to repeat myself because I think it's important. I find it useful to put a layer of plastisode or some soft EVA on top of that. This is, I think, an important design here because a lot of these types of shoes, the post-op shoes and things, there's no structure to the back of them. A lot of them don't have counters. So you put somebody in there that they've got some sort of deformity. Even if they don't have some sort of deformity, there's nothing holding them on top of that little platform that's on the bottom. This particular shoe has a little bit of a counter in it, but it has that strap that comes over the instep. They call it a heel retaining strap. That really keeps the heel back where it belongs, keeps the shoe on, provides some, because it's pulling on the heel, it has some support for the calcaneus. And it's pretty darn important in this particular shoe to keep the foot in place, because this is that DH pressure relief shoe. You're going to take those pieces out in the bottom to provide relief, but if the foot is traveling inside of the shoe, that relief isn't necessarily going to be where it belongs if the foot is moving within the shoe. So that heel retaining strap, I'd like to see it on all of these types of shoes, because there's nothing, if you don't have something like that, there's nothing keeping that foot in place. It's got a removable toe cap, so that toe cap that you see there, actually you can lift up the insole, and it's got Velcro, and you can actually take that cap out or leave it in there. There are times when the physicians would want some more air movement in there and not have it confined. Some of these things can get a little bit messy if people are wearing it for the better part of their day, and if they do have drainage or whatever might be going on with their foot, it sometimes can be advantageous to take that toe out. So it's nice to be able to have that option. A rigid wedge sole, not necessarily a rocker, but you could always easily modify it, but we do quite often, and add a rocker sole to it. Velcro closure for adjustability. You know, a lot of these folks may have edema. If they're very often, if it's a post Charcot foot, they may still have some swelling that has to go down. And also, these folks are going to wound care clinics on occasion, getting dressings. Those dressings aren't always the same. So if that dressing changes from time to time, you've got the adjustability of that Velcro to adjust to the changing bulk. This is a Darko product. Again, this is for unweighting the heel. There is something under the heel. It's a piece of plastic or whatever under the heel, but there's some flexibility there. It's got a cushioned insole, but you can certainly add something in place of or on top of that cushioned insole, because you've got Velcro upper, Velcro closures. It works. I mean, there's still something under the heel, but it stands to reason there's not going to be the major part of the weight when they come down. Theoretically, on heel strike, they're going to be hitting distal of the heel, so there is going to be unweighting there. This was the one we started with, was the Ortho Wedge Healing Shoe. Again, it's got a cushioned insole, Velcro closure, a little bit of a heel counter. Well, no, this wasn't the first. The first one was the IPOS. We'll see that in a minute. This was the second version. I'm going to take that back. But this unweights the forefoot because there's nothing under it. Again, it's not real flexible, but you'd be surprised that this really does unweight that forefoot by not having actual structured shoe underneath it. This one is it can work very successfully, but people have to know how to walk on this, and I'll just editorialize a little bit on this. If you give this to somebody, or you could advise the people that are coming in that got it from the wound care clinic or something, they can't just walk heel to toe with this thing. They need to walk with a flat-footed gait, and of course that's going to help unload the front. It'll decrease on some of the shearing and everything else that's taking place. But this should be just a flat-footed gait. I've seen people that walk heel to toe with these things, and they literally wear the entire front of it out, and they just grind it off on the pavement by walking heel to toe. So you can't just throw these at people and not explain to them what it's supposed to do and how to use it. This was a Darko wound care shoe. I think this is still available. This was something that Nancy Elfman had actually come up with when she was working with Darko, and this was a nice shoe. It had a very significant rock built into it, rock on the heel and the toe. It had 3-layer EVA and foam insole, so you could take these different layers out, cut parts of it out so that you could create reliefs in certain areas. Uniquely, it had a leather upper, so this thing had some real guts to it. It had some real structure to it. This is the heel relief shoe, and again, this one's from IPOS. With this one, there's no pressure on that heel whatsoever. It's got a cushioned insole and absolutely nothing under the calcaneous, which is really good because you're totally relieving pressure, but of course it's a little scary because that heel's just sort of dangling out in midair. This again has to be somebody that understands why they're using it and how to use it. It's got to be very careful. And this one, there's no structure to the sides of that. So if somebody had an unstable foot, probably wouldn't be the best bet to put them in that. And this was, I should reverse these because these were the first boots that came out initially, relief shoes. This was the negative heel shoe from IPO's forefoot relief shoe. And it actually came out for people, the first places I saw it was in the orthopedic clinic for people that had forefoot surgery and wanted to offload the forefoot, and I have not have anybody walking on the pins that were put in the people's feet or the corrected bunion. Cushion insole, Velcro straps again, and it totally loads the heel. It's a negative heel design. But it's pretty scary to have those toes dangling out there in midair. And again, I know a lot of physicians initially that used it and it was successful, but especially if now post-surgically, obviously that person is going to be extremely careful with those toes because they hurt like the bejeebers. But with that diabetic patient, if they had an ulcer and they're put in that for a diabetic ulcer, they don't have any sensation up there, many of them. And they're not going to think about banging it into a wall or when they're driving. Who knows? They shouldn't be driving with that. But an insensate foot in there is sort of dangerous. They did come up with a metal toe guard to put around it, but that one's a little controversial on just having those toes just dangling out there in midair. It's a little scary. And then the custom-made Plastizo healing saddle, and this was something that Dr. Brand actually was a big advocate of. It's a custom-molded footbed, lightweight, rocker sole, Velcro strap, sort of a sandal design. Really, it's a total contact foot orthosis made into a sandal. And at the time when Dr. Brand started, sort of introduced and came up with his idea of the total contact cast, we didn't have, I know it's for some of you younger folks, you won't appreciate this, but there weren't in-depth type shoes like we have today. There weren't shoes that came in multiple sizes, multiple widths, and with removable insoles. And so Dr. Brand really had some issues when he'd take people out of the cast. And if you understand, I'm not talking about Charcot today, but you know, if they're trying to heal an ulcer with total contact casting, those folks could be in a cast for 3 or 4 months. Well, when a foot is in that kind of a protected environment, when it comes out, the whole foot needs protection, because it really is, as I said, in a protected environment, and all of a sudden you're exposing it to all the dangers of footwear and walking barefoot and gait. I mean, everything. So Dr. Brand found if he was taking people out of the cast and putting them into shoes, he was getting some breakdown. He wasn't happy with that. So he came up with this idea of the custom sandal. And it's a very unique design. I don't do as many of them now as I used to, but because I don't have the physicians that really understand it and are advising it, and there are some options. There's some good options out there for something like this. But Dr. Brand used this as interim between the casting and the shoes. And he found by putting them in something like this for 3-4 weeks, the skin had a chance to sort of toughen up and adjust to the environment and the rigors of walking and everything else. And he had much better luck putting him in this for 3 or 4 weeks and then putting him into the shoes. Obviously, when the extra depth shoe came along, it wasn't nearly as serious. It wasn't as much of a problem. I still will make these on occasion for people just so they've got a shower shoe. If they've got a lot of deformity, there's nothing that's going to go on their foot. And if someone has a rocker bottom foot and they're not supposed to stand on it, how in the world can you stand in the shower? I mean, some type people will say, well, I'll stand on my heel. Well, I think that's a little unrealistic that you're going to stand for 5-10 minutes in the shower on your heel. You're not going to. You're going to walk on that plantar prominence, and theoretically soon it's going to break down. So you can see here, it was, if you look at the cutaway part, it was, that blue plastisode is #1 plastisode. Years ago we ordered it special, so it's #1 plastisode, pretend it's pink. And then you can see the white layer. The white layer is #2 plastisode. So that was all molded over the cast of the person's foot, just like we'd make a total contact foot orthosis. On the bottom, that's a layer of probably 1/4 inch or more of polyurethane foam for cushioning. And then we use black plastisode around the outside. The black plastisode is very, very rigid, very, very lightweight. And in between the original mold or the footbed, we'd put Velcro straps. This one is just one across the front. Sometimes we'd put them back around the heel. We put that black plastisode around the outside and then build a rocker sole into it. So it's a custom foot orthosis made into a sandal, and it really, really worked well. All right, so let's look at some pedorthic management, and some of this is going to be a repeat of what we already talked about, but maybe for different reasons. So for our objectives for the diabetic foot, of course, transfer and relieve high pressure areas, reduce shock, reduce shear, and accommodate deformities. And we get a lot of different deformities when with the diabetic foot. I mean, we talked about amputations, but it can be for a lot of different other reasons. Stabilize and support deformities. Now, when we're talking about diabetic foot in general, we can have fixed and flexible deformities. I could have done a talk on Charcot foot today, and maybe next time we get together I could do that. But we can have very, very flexible feet, and we can have rigid feet. A lot of the Charcot feet will be casted. We talked about casting for ulcer closure. We also use a total contact casting or those walkers to stabilize and protect the foot during the Charcot process. And if that's done long enough through the whole process, the coalition and everything else, then that foot will end up being rigid. It may be very deformed, but it will be rigid. If that wasn't done, and I've had patients that had Charcot, didn't recognize it, and kept walking on it, and luckily didn't have an ulceration, and they've got feet that are like a skeleton that's put together with elastic laces. I mean, you've seen some of the skeletons that are elastic. I mean, there's nothing to them, and that's what a foot can end up if they didn't have casting or immobilization during their Charcot process. So we can look at feet and one might be fixed and one might be flexible. Managing those feet can be very different because that real flexible deformity is really hard to manage because you have to apply a certain amount of force to keep it in place, which potentially could result in an ulceration. So we have to really take that into consideration when we're looking at our pedorthic modalities. And then there can be, everybody isn't insensate. You can have inflamed, painful, and unstable joints. How do we accomplish these? In-depth shoes, shoe modifications, foot orthoses, and even custom-made shoes. So we'll just go through these and take a look at them. So plantar ulcerations, what am I doing? I'm going to go by that. So let's look at shoes. The shoes, obviously we want the shoe shape to match the foot shape, and that's really becoming more of a challenge today. And again, I have no idea the age range out there, but any guys or gals that are more my age and have been doing this their entire life, we used to have companies that gave us a lot of different lasts. We still have the sizes available, but we don't have the variety of lasts. So that can be a little bit of a problem. We used to have shoes that were very specific shapes, and we'd match the shape of the shoe to the shape of the foot. We even had wide lasts that would work for the Charcot feet. Today, the manufacturers, and a lot of it is because of cost. It's because of inventory and manufacturing. Basically anybody that's getting diabetic shoes and they're doing it on the therapeutic shoe bill, the price point of that shoe has to fall within what is being reimbursed, basically. And so that created a real issue for the shoe manufacturers. So instead of having so many lasts, and I don't know that even the shoe manufacturers understand why they've done it, but we used to have very specific shapes. We've gone to more generic shapes, broader toe boxes. Some of them have wider midfoots, and we've gone from multitude of widths, such as AAA, AA, A, B, C, D, E, double E. We've gone to narrow, medium, wide, wide, extra wide. And we've had to do that. So the shoes don't fit as intimately as they used to, so we're making them fit with what we put inside of them. But when we're talking about our diabetic patients, that's ultimately unbelievably important. You have to be sure that not just the upper, but the sole part of that shoe has to fit that foot as well. I talked about the base of the fifth before. It can be the medial arch. If it's a real severely collapsed medial arch, remember that foot is sitting down in the sole of the shoe, so we've got to be sure that foot's not sitting and rolling over the side of that shoe, or we're going to get ourselves in trouble. We've got shoes with additional depth, and I just fit somebody with one of those earlier this week. Some of the feet are extremely, extremely large. If we've had Charcot deformity, if we have people with severe edema, bracing. One lady that she's got this humongous brace that she's got to wear in addition to her shoe. There's no shoe that will go around all of that, no typical shoe. So we've got shoes that, the whole front of the shoe will open up. We've got the stretchable shoes. So we've got to look at other options than this sort of the standard shoe that we would offer people. And people have to be open to the fact that they need some of those types of shoes. Sometimes they're not the most attractive shoes, but we've got to accommodate that foot, because if we've got that diabetic foot, especially that's had an ulceration already, they're so susceptible to breakdown again. We've got to have that appropriate shoe. That's the foundation of everything that we're doing. Strong counters are important. We like to talk about long medial counters, but that's a thing of the past pretty much. But we do need a strong counter. We're going to be, with a lot of these feet, we're going to be putting more accommodative type inserts or even foot orthoses. You may be making custom foot orthoses, but it's not going to be a rigid piece of plastic. It's going to be an accommodating type device. So but we still want some structure to that shoe. We want some control, and the control all comes from the heel, really. If you can control the calcaneus, you can do a lot to the forefoot by controlling the heel. So very, very important to have a shoe with a significant counter in it. And the counters are no longer made out of fiber board or anything like that. Most of them are plastic now, which I'm not real in favor of, but that's what we have, again, because of cost. We've got the manufacturers have to make us shoes that fit in our in a particular price range. So a lot of it's gone to plastic, but that plastic, if it's a leather shoe anyway, you can heat that up. You have to be very careful, but you can heat that and mold it to a certain degree. If not, you can open that counter and cut some of that counter out if you have to, if it's creating a pressure on a prominence, perhaps on the calcaneus. Shock absorbing soles. We don't see too many leather soles and rubber heels anymore. You know, I think a great thing that's happened is using EVA midsoles and you know, more rubber or longer wearing outsoles on the shoes. Of course, the problem with that is that EVA can compress. With the population that we're dealing with, a lot of those folks don't think the shoe is wore out unless they look at the bottom in the sole. The sole part of the shoe is worn out. But it's hard, but you have to convince them that that the EVA can wear out, and then the shoe is basically worn out. The EVA will take on the position or the shape of their foot, so it could be worn out. It could be compressed on the medial side or the lateral side. It isn't just the wear that's on the bottom of the shoe. But putting the EVA in there makes those shoes lightweight, which people appreciate, and it provides shock absorption, but it does compress, it does bottom out. A lower heel. Most of our shoes now are basically built on probably 3/8 or half-inch heel heights, the shoes that we're using in our practices, which really is good because so many of our feet are flat. We've got rocker bottom feet, that flat insole in there. You end up with a taper in the insole if you've got a 1-inch heel or more. So most of the shoes that we have are pretty flat inside, which makes fitting a lot easier. And also, you can see in the picture here, I mean, I don't think too many of our diabetes people are, at least if they've got complications, they're not walking around that high heel. But as it doesn't have to be a 2-inch heel. Going from a half-inch heel to a 1-inch heel will increase pressure on those metatarsal heads and even the toes. So the lower heel, I think, is something that's come around that is a good thing, actually. Stretchable uppers are great for accommodating the hammer toes and the bunions, and I use it sometimes for those people with real severe edema as well. There's a fair amount of give to some of those uppers, and that's very helpful. Rocker soles. I think a lot of you know me, and you know me that I could probably talk for 2-3 hours on rocker soles. Very important modification. We don't have too many shoes that have, we have some, but don't have a lot of them that have a true rocker sole. I'm not talking about a Skechers rocker sole that you're going to tone your lower anatomy with, but the rocker soles that we're making, we can reduce pressure, and we can reduce pressure anywhere on the foot. We can reduce pressure on heel strike. We can reduce pressure in the toes, the metatarsal heads, and with the double rocker sole, we can reduce pressure in the midfoot with those rocker bottom feet. So depending on how, a rocker sole is not a rocker sole. A rocker sole should be specifically designed for the foot that you're putting into that shoe in that modification. We can reduce impact shock by the way we taper the heel, limit motion of joints, put an extended steel shank in there and add that rocker sole. The foot's not really bending at all, and improve weight bearing. So the rocker soles are very, very valuable with our diabetes population. And we're talking about ulcerations here. If you had ulcerations on the metatarsal heads, we'd want a toe-only rocker sole and transfer most of the weight to the back. If we had a calcaneal ulcer, then we can provide a real nice significant rock on the heel, and we'll decrease a lot of the shock on heel strike. There's evidence, there's research out there to prove this stuff. Flares, you know, we get a lot of, with different deformities, but also with the amputations, depending on where they are, you may have a foot that's actually tilting medially or laterally. I mean, there can be deformity both ways. We get into the Charcot joints as well, but the amputations can cause that. So you know, when we look at the flares, they're very, very helpful. We want to try and keep an ulceration closed. Then we've got to stabilize that foot and keep it in a normal position. Our foot orthosis is going to help, but adding flares to the shoes will really help a lot with maintaining position, reduce ligament strain, and just give us a broader base of support. The relasting, I'm sure some of you have seen me talk about this before. Remember I said if the shoe we're using doesn't accommodate the plantar aspect of the foot and it's rolling off of the side, medial or laterally, both, we can relast. And what we do here is we literally cut through the entire shoe and widen it to fit the plantar aspect of the foot. What I've done here, put a piece of EVA in there to hold it open, and then I use a viscoelastic polymer. I pour viscoelastic polymer in there. You could just use a piece of EVA and put in there, but that's sort of like a jigsaw puzzle or something to try and get at that exact shape. But with the polyurethane soles that we have now, they're so terribly flexible that it's really easy to do this modification. You just take the original outsole off, that's the more rigid part of it, and you can just cut through this with a knife, widen it, put that filler in there to hold the place, and I put a temporary insole, or you can use just like a piece of file folder inside that's not very thick, and then whatever you're going to use to fill it, you do that from the street side of the shoe. And now you've made that plantar aspect of the shoe fit the plantar aspect of the foot, and it's not going to be rolling off of the side. I do this here. We did it medially for a charcot. I do it a lot for that base of the fifth. With the base of the fifth, it's very easy. You make a little cut either side of the base of the fifth metatarsal, and you just bring that out, and then you've got shoe under the base of the fifth, and you've equalized the weight bearing. You don't have any more pressure in that area. Steel shanks in conjunction with your rocker soles are certainly valuable, or carbon fiber. I, again, use more steel. The carbon fiber is harder to shape to fit the plantar shape of the shoe. You can get them pre-shaped, but they don't necessarily always fit the shoe. So again, with the steel, you can shape it, you rough that steel up, and you can cement that into the rocker sole when you put the rocker sole on, and it's not going to go anywhere as long as you've shaped it properly. The SACH Heel, again, if you had a calcaneal ulceration, I always use this. I talked to you about the hindfoot containment orthosis. Even if it's not something that involved, I'll use the SACH Heel if I've got some sort of a calcaneal ulceration, because it's so great at decreasing that shock on heel strike. Now, this is something that I do a lot. In particular, I mean, I'll do it all over. I'll do it in the midfoot for a charcot, in the heel if I've got some of our elderly population, they have no fatty tissue anymore and they'll get calcaneal ulcers. Then I'll drill out in the shoe under that. But here I do it up for hammer toes. You'll get those real prominent metatarsal heads that it's reoccurrent ulcerations. What I do is just identify where that is and use a drill saw, drill a hole right under that metatarsal head, and then fill that in with material that's half the thickness. And then you've created this real nice relief area inside of the shoe, and those ulcerations just close like nothing. It's so simple to do it. You can try and do some of that with your foot orthosis, but to offload a prominent metatarsal head, you have to put so much on the foot orthosis that you lose a lot of the room in the toe box of the shoe. You just have so much room to work there. It's not like working in the midfoot or the heel. Here, you provide the relief by literally taking the insole and part of the sole away, and it really works well. So the total contact foot orthoses, we want to equalize weight bearing, obviously, decrease or eliminate weight bearing if possible. But again, always remember when I say decrease or eliminate weight bearing, you're putting it somewhere else. And I stress this, and I'm sure all of you know it, but we tend to forget it. Okay, you're going to offload a metatarsal head that was ulcerated. So you build a relief area, you build up around it. And I have seen a lot of situations where people did that. The patient comes back in a month or two, and they've got a new ulceration. Where's the ulceration? It's under that place that you offloaded. So just be real careful. Always remember, when you offload, you're loading. The two go hand in hand. All right. I've got a couple case studies. I think I'm going to. Are there any questions, Elizabeth, or should I do some case studies?
Case studies would be great.
All right, we're gonna go with case studies, and then we'll let you guys. I don't know. I think you're done for the day, aren't you? After I'm done, but we'll see.
Everybody that is not taking the approved clinical mentor program, which starts at 3:45 with Chris Robinson, is finished after you've finished your case studies.
All right. Then I'm going to do a few case studies to wrap this up. I think it sort of helps bring all of this together. So this is a young lady. This is an old slide. I still take care of her, but I'd like to show these because when you see the shoe, you're going to say, "Are you kidding me, Dennis?" But we still take care of her and do the same thing. But they're sort of handy slides to have, because this was years ago when we didn't have depth type dress shoes, and today, I mean, you can even get dress shoes with removable insoles. Life is good today. It was not as easy 40 years ago. And she had a reoccurrent second metatarsal ulcer. You can see the prominence on the picture on the left. And she had a cavus foot. I mean, it's not severe cavus, but that arch doesn't go anywhere. She had a pretty significant arch. Hammer toes, not a real severe bunion or anything, but she had those hammer toes and reoccurrent ulcer. When she finally got that closed, the doctor said, "You need special footwear." So she went to one other facility in town, more of a shoe store type place, and they said, well, she had to wear, at that time, PW minor oblique-toed shoes. Well, she wasn't going to wear PW minor oblique-toed shoes, so she told them whatever she told him. And she went back to the doctor, and he said, "Well, give Dennis a try." So she came in to me, and we went through the same whole thing, and she just said, "I'm working." She said, "I have to wear a dress every day to work, and I'm not going to wear that type of a shoe." So now she doesn't have severe deformity other than that dropped second metatarsal. So I told her, and I still do some of that. I sort of made a deal with her. I said, "You know, I've got to go full blown on this thing initially. I'd like to make you a total contact foot orthosis, build relief into that, the rocker sole, and I can do that on an athletic shoe. If you'll try that and that works, keeps you closed, then I will try and find a solution for your dress shoes." And she bought into that. And this is what I did for her. Like I say, that's an older shoe, but we still do the same thing basically, except now we have removable insoles. I didn't have a lot of room to work inside of here. I took what I could out of there, some foam and a plastic sock liner or something. I put a piece of polyurethane foam in there for a little bit of cushioning, and excuse me, a piece of EVA cut out under the second. So I loaded 1, 3, 4, and 5, and unloaded 2, but I did the same thing on the outside of her dress shoe. And so it was sort of a rocker metatarsal bar combination, and offloaded 2. And you can see, this is after she wore it for a while. You can see she's still touching it. She's wearing there. And the deal was she could wear that during the day, but when she came home at night, she would put her athletic shoes on. And she agreed to do that. And she's had some reoccurrences, I think, when she's cheating some, but for all practical purposes, she stayed closed for probably 20, 25 years. And the kicker on this one is she was a diabetes educator. So she knew how serious this was. She knew what was going on with herself, but she still wasn't going to make a compromise and wear what I would call a more appropriate shoe. So here's a young fella, second metatarsal. I don't know why we got second mets here, but second metatarsal ulcer here. And I bet you, I can't see it from this one. This is an older slide. Some of this is new, some of this is older. But he had a fairly high arch, and you can see that prominent base of the fifth here. That's a very common thing with this population. So he had an ulceration, and he was a young guy. He did not have decent insurance. and he needed to go back to work. And so the logical thing here, the docs would have put him into a total contact cast, but he couldn't go back to work in a total contact cast. So this was out to medical college. I knew all the docs. We were all working together. So what we did there was put him into a high top work shoe, steel shank, and a real significant 4-foot rock on it, and then built the orthosis and offloaded that area. And he was back at the clinic every couple of weeks to have that debrided, and we totally healed it in the shoe. I'm not bragging about that because I'm not excited about doing it that way, but this way we were able to keep the guy going to work and actually close that ulceration. Now here's a guy. This is this man's had tons of surgery. I don't know if you can see. He's had metatarsals, one toe amputated. There's scar tissue in different places on the plantar aspect of his foot, and he had that long-standing ulceration, and it was finally closed with total contact casting. Now, you can look at this. I'm sorry, the picture should be bigger, but the picture on the right side is after that ulcer finally closed. Now, if you look at that, it looks nice. There doesn't look like any prominence there, but look at all the scar tissue that's there. And what will happen with that scar tissue if you don't offload it adequately, it will keep building up callus. And if you build up enough callus, eventually that'll peel off and he'll have another ulceration. So you really have to, even though that foot looks pretty darn good at that stage of the game, you really have to give it a lot of protection. So, and here you can see again on the dorsal aspect of some of the scar tissue that he had from the surgeries. So what we did with him was a foot orthosis with a well, and just to get all the weight off of it. I didn't want anything touching it if I could manage that. And then this rocker sole is what we call sort of a Carvel type rocker. There's not much rock to it, but it goes from the apex to the toe. So the theory being that that part of the foot never touches the ground. It never comes in contact with anything except the shoe itself. A little bit, not exactly, but a little bit, the concept being like the negative heeled wound care shoes. Okay, so here we've got a guy, 62-year-old male, type 2 diabetes, and he had this ulceration on his calcaneus. And it was a very, very deep ulceration. And you can see from the x-ray, he was so lucky because that wound was so close to his calcaneus. And Vascular was actually working with him, and they could not get it to close at the end. I mean, they had revascularized him and everything else, but there was no way they could get that thing to close. So it was a big defeat for them to have to send it to ortho. At that oftentimes different departments really don't like to cross-refer, but they had to give him to ortho. So we did get it closed in the orthopedic department with total contact casting. But then that's a tough one. I mean, there's so much scar tissue. There was that big deficit, and the challenge was, are we going to be able to keep that thing closed? So what we did was first off a rocker sole. And there we put a real nice rock on the heel because you can decrease shock. There's evidence to show you can decrease rock and shock on heel strike with a nice rock on the heel. But in addition to that, we added a SACH heel. So on heel strike, we were trying to advance the weight-bearing stresses as distally in the foot as possible and keep it away from all that scar tissue on his calcaneus. And then we made him a foot orthosis that was very, very deep. And you can see on the cast, we followed the contour of his foot. You can see that's where the deficit that was in his foot is in that cast. We made that foot orthosis, and then we filled that all in with a real soft viscoelastic polymer. We had to contain it. You can see we've got something around the outside. That viscoelastic polymer was like if you grab your palm, the fatty tissue in your palm, that's about the consistency that was. We had no offloading theoretically. We totally had total contact with that heel, but we added that viscoelastic polymer to it. That, along with the rocker sole and the SACH heel, I'm not saying when I give you these cases, not that we don't do adjustments, but actually that gentleman went to his grave with that foot. I mean, he had no further breakdown on it. Okay, here, this is an interesting one, and then we'll end it. I'm sure Elizabeth wants me to shut up in time. So,
Never.
Here, oh,
You do
right.
have a question, so when you're done, don't just
Okay.
hang up.
Oh, I wouldn't hang up on you. I'd be in trouble. Here we've got a 55-year-old male. This when this was taken, and I had been taking care of him for a while already. Type 1 diabetes, so he's had diabetes most of his life. And he had toe amputations. If you look at the right foot, it looks like, well, if you just look at that, you don't even see that he's had an amputation, but he lost his third toe. And then on the other side, when he came to me, he had an ulceration under his first metatarsal. And it was one of those situations where the doctor wasn't really helping me out on this one. And I was trying to offload the ulcer. It was probably under one of the sesamoids. And his wife and he would come back. They were a great team. They'd come back and say, well, it's almost closed. Well, it wasn't almost closed. The callus was almost closed. And then they'd come back for a recheck in 2 weeks. They say, oh, he's got his ulcer back. Well, the callus fell off. Eventually, he came to me. He said he had a lot of pain in his foot, which didn't make sense because he's insensate to his knees, actually. He had pain, so I said, well, come right in. I want to take a look at you. And he ended up with an infection in that first metatarsal. So I called his doctor then and said, you've got to see him right now. So he had his great-toed first metatarsal, partial first metatarsal shaft removed. Somewhere along the line, he never knew it. He actually had some Charcot involvement in there as well. So pretty complicated feat. His right foot that I said he had lost the one toe, he's got a cavus foot on the other side. So a very unique feat. And I'm going to go sort of quick here, but what did we do for him? He was obsessed with protecting his toes, though nothing falling on his toe ever had anything to do with what's the problem. It was all plantar ulcerations, but he was obsessed with protecting what toes he had left. So I had to fit him with a steel toe. So I found this oblique-toed steel toe. We put rocker soles on him, foot orthosis with a filler for that great toe, plastic top cover, obviously. And this guy was so obsessed with saving his feet, he had 3 pair of these shoes, and he never wore the same pair of shoes 2 days in a row. He alternated shoes every day. And I kept these feet going he was with me for like 20 years, and he was a mailman. He was delivering mail with those feet every day. So anybody says it doesn't pay, you can't. I hear it sometimes when I'm on the podium with some physicians. I was just recently at a meeting and I was so frustrated because the guy said if you have to do 1 or 2 amputations on a patient, you might as well just cut the leg off and just be done with it. I think this is an excellent example of, no, you don't necessarily. I'm not saying I can avoid ulcerations by any stretch of the imagination, but he was a mailman for 20 years until he retired. So we can make a big difference in people's lives, trust me. I'm going to end it there.